All right, so it looks like we're recording.
Okay.
And I think we can go ahead and start with introduction.
So good evening. Let's go ahead and get started. Welcome to the fifth mini medical school of 2021. My name is Katie Smeltzer, and I'm a first-year medical student here at IUSM Terre Haute, and I'll be one of the co-moderators for tonight.
My name is Katie Lawson. I'm also a first year here in Terre Haute, and I will be the other co-administrator.
As you can see, the format tonight is a little different this year, being held over Zoom, but we're happy to have you guys tonight with us virtually.
So before we get started, we're just going to go ahead and introduce some of our sponsors and thank them before we introduce our speaker tonight. We have the Hamilton Center, the Indiana State University, IU School of Medicine, Terre Haute, the Lugar Center for Rural Health, Minority Health Coalition of Vigo County, Terre Haute Regional Hospital, Tribune Star, Union Health, Via Media, West Central Indiana, AHEC, and WTHI TV.
And finally, I'd like to explain the logistics for tonight's event. The Zoom webinar platform allows us to feature our local expert panelists. All other attendees will be muted during their presentation. We encourage you to submit your questions during the presentation using the Q&A button located at the bottom of your screen. Your questions will be answered by our panelists following a brief intermission after their presentation. Tonight's topic will focus on cardiac health.
So just to introduce our panelists tonight, we have Dr. Samit Bhatheja. He is an interventional cardiologist here in Terre Haute. He is a graduate of the Medical College of Baroda, India. He also earned his Master's of Public Health from Eastern Tennessee State University, where he completed his internal medicine residency. Dr. Bhatheja is also completed a cardiovascular disease fellowship at ETSU, along with a fellowship in interventional cardiology at Mount Sinai Hospital in New York. While he was there, he received the Interventional Cardiology Fellow of the Year Award. Dr. Bhatheja was recognized as a featured fellow by the Cardiovascular Research Foundation and received the Impella Scholarship from the Transcatheter Cardiovascular Therapeutics. He is currently working on the cardiology team here in Terre Haute at Union Health. Without further ado, Dr. Bhatheja, go ahead and start your presentation.
All right. So can you hear me clearly? All right. I feel good about myself about that introduction. Thank you. Okay. So living with heart disease. If I start out by statistics, it's going to make everybody's heart sink because 200 Americans die every day from heart disease. There are about 700,000 deaths a year, and it's the #1 killer, no doubt about that, all the heart disease put together. But we are here to not concentrate on the red part as much as the green part, which is called living. So living is a positive word. So even though I threw that stats up front, I'm going to get them out of the way so that we can concentrate on living rather than suffering or dying from the heart disease. Living with heart disease, if my computer works, there you go. There are a few things patients should concentrate, and I would like patients to concentrate on, because that eventually helps them taking the right decision about their own health care. I see about 10% of the patients in my practice who take everything in their hands and they keep going until every stone is unturned, and I see positive results with that. Out of the rest 90%, 40% go not full 2 miles, they probably will go 50% of it. What I'm trying to say about that, this chart, the cartoon you see on your on your computer screen right now, it depicts few things which patient or family of the patient should be aware of while managing the heart disease. And more parts you cover and you're aware of, you're trying to go all the way, trying to live as healthier as possible with the heart disease. So the 4 quadrants I made here is knowing your condition well. And most of the patient, 90% of my patients are good at this part, knowing your condition well. They do, I mean, Google is available and Alexa is there. She'll tell you stats. And so you have multiple platforms available for information these days. Of course, you want to go to more reliable platforms so that you don't get mixed information. Of course, efforts like this can help getting some advice, but when you're out of these sessions and you have questions out of these sessions, some resources like CardioSmart, that's the resource by American College of Cardiology, and heart.org, which is the portal made by American Heart Association. They have wealth of information available, which is very reliable. Now, coming back to these 4 quadrants or 4 points where I like my patients to concentrate on, knowing their condition, most of my patients do well. Most of my patients do also well with know your do's and don'ts about the heart disease they are suffering from. But when it comes to the right side, knowing your medication, as I said, more than half of my patients fall short, because this is very important. You are putting a chemical in your body to help you, which can potentially hurt you at times. And it's very important to know your medications, why you're on, what you're on, how much can help or hurt you. So knowing your medication probably is one of the important part which can help improving your condition and eventually can get you through the hard or rocky part of heart diseases. So again, as I said, knowing your condition and knowing do's and don'ts, most of my patients do well. But what I see, knowing your medications, sometimes when I ask my patients reverse, hey, do you know why you're on this particular medication? Some of them, they don't know. And I don't blame my patients for that. What I'm trying to say is it is very important for family, friends, whoever is going with, and the patient to concentrate on this part as well. And of course, knowing when to get help is important, because looking for those warning signs, looking for those signs which will tell you that now the condition is getting worse and it's no more manageable at home. I need expert help at this time. Reaching out to your healthcare provider, reaching out to your cardiologist in this instance, and sometimes acute care, going to the emergency room. So knowing when to get help is very important and saves lives. Because most of the heart diseases, they're chronic in nature. And while the chronic phase is maintained or kept under check by medicines and lifestyle do's and don'ts, which we're going to talk more about down the lane, knowing that the chronic diseases can have intermittent spikes, something will come in life which will derail you from your path of maintenance. For example, heart failure patient, it could be a small party and a bag of potato chips full of salt. That's enough to put them off the path. So, and recognizing those things, especially the symptoms which will put you off your path, will help you putting you back on the path. So staying on the track is the motive behind managing heart disease and living with heart disease. So we're going to be majorly touching these 4 themes today. First one is heart failure, one of the leading cause of hospitalization for heart disease in patients. And the second one is the number 1 killer in the world, that's the heart artery blockage. The third one is heart rhythm problem. I chose these 3 specifically just to touch points on these 3 heart problems. And then at the end, we will see heart healthy lifestyle, how that can help us keeping ourselves on track. Those who don't have heart disease can avoid heart disease, and those who have heart disease can manage and keep it under check. So let's move on to heart failure. Again, if anyone has heart failure out there, they are not alone, because almost 6 million Americans have heart failure. And again, touching at all those 4 quadrants, knowing about how to live with heart failure. Initially, when my patients get to know that they have heart failure, it's a scary feeling, and it is okay to be scared initially. Most of my patients' reaction is, oh, is my heart is working okay? Has it stopped? Is it going to stop working? Heart failure, what is heart failure? So heart failure does not mean that heart is going to stop. If a student fails, he fails in an exam because student did not study. That's the job of student. Same way, heart failure, what's the job of heart? It's a pump. If it fails to pump good enough that blood reaches top of the hair, the bottom of the toe, everywhere in good amount with nutrition and oxygen, if heart is not able to pump efficiently, or it's not able to get the blood out there in efficient manner, that's heart failure. Because you'll be surprised to know some patients have heart failure in spite of having normal heart pump. We're going to talk about that in a second. So you would say, oh, my heart is beating okay, my heart pump is okay. Why the heck I have heart failure? So that's what I'm saying, that when heart fails to get the blood out to the body in an efficient manner, that is called heart failure. Do's and don'ts, of course, heart failure puts a stop sometime on physical activity, sometime on the diet, what you can eat, what you can't eat. Salt is one of the biggest culprit out there, which helps retaining fluid and causing heart failures. But and physical activity wise, initially when you're suffering from heart failure, sometimes patients, until they get diagnosed, they don't know, because until then they're suffering from their symptoms. We're going to go over those symptoms. So when the heart is not able to pump blood efficiently forward, where it's going to go? If the blood is going to back up, if it's not going to go forward in the body by the pump, it's going to back up in the lungs, and that's going to create the shortness of breath, the fatigue, the swelling symptoms. One of the subtle symptoms of heart failure, not just swelling and shortness of breath, the blood which backs up in the body because heart is not pumping efficiently forward, it also your gut. Like the legs, ankles, they can swell up from the fluid buildup, back up. Your gut can swell up as well. And when the gut swells up, well, your appetite goes out of the window. And loss of appetite sometimes can be a sign of subtle buildup of fluid on the body. Return of appetite, usually I ask all my patients who are getting better from their heart failure, return of appetite in turns tell me that they are getting better because swelling in the gut is going down. So swelling, ankle swelling, shortness of breath, fatigue. And when the heart failure progresses, it can reach the point that patients are not able to sleep at night, especially flat on their back, because when they're up about walking around in the daytime, all that swelling or the extra fluid from the backup of blood goes to the legs, to the feet. So they are okay. But when they go to the bed at night, all that fluid, now gravity is not working anymore, so that all fluid they accumulated at their ankles returns back to circulation. Now it's too much for heart to handle. Well, it backs up in the lungs, and they get up in the middle of night gasping for air, using more and more pillows just to sleep comfortably because of the shortness of breath. They're using a pillow before, now they're using 2 or 3 pillows. Some of the patient, they come and tell me, hey, I've been feeling short of breath for the last couple of months, and I've started sleeping in recliner now because I feel more comfortable sleeping there. All those could be signs and symptoms of heart failure. All these symptoms happens because of the backup of blood, because heart is not pumping it efficiently forward. Knowing your medications, again, very important part. When patients get diagnosed with heart failure, it's very important for them to know that there are 2 kinds of medicine. If I give an analogy of an infection or a fever, Just going off track, I know we're not talking about heart. This analogy is about infection. So if somebody has urinary tract infection, but they come in with fever, if I just give them Tylenol, it'll get down their fever. Are they going to get better? For a little bit, not forever. They will eventually need antibiotics, diagnosis of where the infection is. In this instance, it's in urine. You treat the infection gets better, fever goes away. So giving Tylenol is important so your fever doesn't go too high, but just giving Tylenol is just a patchwork. We are putting a rug on the problem. Now, bringing back the same analogy for heart failure, there is a cause behind why heart pump is failing. So we need to find out why the heart failure is there, and then reverse if it's a reversible condition. For example, if it's blockage, you can reverse the blockage, improves the heart pump back to normal. If it's arrhythmia, you treat the arrhythmia, it brings back the heart pump back to normal. Well, in some instances, it can be toxins like chronic use of alcohol, methamphetamine. Sometimes it can run in family. There's some like virus infections. They can attack the heart muscle, and sometimes it can damage it permanently, and it may not be reversible. So knowing that certain causes of heart failure can be reversed and others not, it's important to know what could have caused the heart pump to be weak. And same as if somebody comes with fever, you give Tylenol, gets the fever down, does not help. Same way, if somebody has built up fluid in form of leg swelling, fluid in the lungs, they are not able to breathe at night, giving water pill alone is patchwork. It will get the fluid down temporarily. Well, it's important so that they can breathe and enjoy their life. I'm not saying that the water pills given for heart failure are not important. They are important to control symptoms, but they are still patchwork. We need to find out why heart failure is there. Unfortunately, in many instances, we are not able to find why heart failure. In some fraction of patients, we don't know. It could be a past viral infection, or it could be something runs in families which could have caused heart pump to be weak. Well, medicines do help recovering heart pump. So what I was trying to get at is when we come to the medications for heart failure, there are two major kinds of medicines. One, which control the symptoms, like Advil for headache. Same way, water pill, which is going to control the symptoms. It's going to keep the excess water at bay so that patients can breathe, sleep well, and enjoy their life. On the other hand, there are other group of medicines which help improving heart pump in long run. And every heart failure patient needs those medicines as far as they can tolerate them. There are two major groups of those medicines which are shown to improve heart pump in long run. One of them is called beta blockers. They relax the heart, they reduce the heart speed or pulse rate, they decrease the blood pressure, and they have shown to improve heart pump in long run. So whenever we diagnose somebody with heart failure, we try to start them on beta blockers. So that's one major group of medicine which helps improving heart pump in long run. And it's not a patchwork. It's something is working at the heart level, improving the heart pump, regardless of the cause behind it. And the second group of medicines are related to what we call ACE inhibitors. If I give examples, you might have heard about medication lisinopril. It's one of the popular blood pressure medicines. Valsartan. So those are the medicines which belong to a group called ACE inhibitors. So knowing the knowledge is power. So if you know, hey, there are two types of medicine I'm taking, one which is controlling my symptoms, and the other group of medicine which are working at the grassroots level, helping my pump to improve. Still, medicines are not substitute for finding out what made it weak, because some of the causes can be reversible and can help improve heart pump faster if you can find that out. Know when to get help. Very important, because if your heart failure, when it worsens, it can lead to extreme morbidity and even mortality. When the fluid builds up on the lungs to the extreme cases, sometimes patients get hospitalized. Reaching out to your healthcare provider if you're gaining too much weight. Typically, we recommend our heart failure patients to check their weight every day. That's your way to know that I am gathering fluid weight gain now. If my patient gain more than 2 pounds within 2 days or 5 pounds within a week, we tell them to double up their water pill. And for at least a week, and we check back within a week. If they have gone back to their baseline weight from which it had increased, they go back on their regular dose. Otherwise, we increase it further. Because, as I said, that this is the one most common reason for hospitalization for my patients, not my patients in general. Working with them on outpatient basis, adjusting their water pill can keep them away from hospitals so that they don't catch other problems from the hospital like infections and so forth. And hospitalization can be expensive for the patients as well. So touching on the heart failure, we talked about heart failure, what it is. It's the heart's inability to send blood to the body efficiently. Now, we talked about just a tad bit that heart pump may be normal and still may not be pumping blood out well. Now, that doesn't make any sense, but that's another kind of heart failure we deal with, and that's called diastolic heart failure on the right side of the screen. Systolic heart failure is the one where the heart muscle becomes weak. Diastolic heart failure, well, here heart muscle is normal. It's pumping normal. We realize all the pumps in the world have two properties. It pumps, well, makes sense. Then it relaxes. It has to relax so that it can fill in, so that it can pump the blood forward with the next beat. If a heart muscle thickens up for one reason or the other, which we're going to talk about, heart muscle thickening can lead to heart muscle stiffness. A stiff heart muscle can't relax easily. And when it can't relax easily, well, it's not going to fill in easily. So no matter how good it's pumping forward, if it's not relaxing well, it's not going to be able to push blood forward efficiently, and thus developing heart failure because of that reason. Most common cause of that is high blood pressure. High blood pressure. So blood pressure is the pressure against which your heart is pumping every beat. You realize that your heart beats 100,000 times in a day. And if your heart is pumping 100,000 times a day against a high blood pressure, well, he or she is doing 100,000 times dumbbells. What happens when you do dumbbells on your muscles? They beef up. What's going to happen to heart muscle if it's doing dumbbells with every beat 100,000 times a day? Well, it's going to beef up. It's going to thicken up. So high blood pressure is one of the most common cause of stiff heart and heart failure in spite of normal heart pump. So we talked about the symptoms: extreme tiredness, weakness, change in the body weight, feeling lightheaded because, well, heart is not pumping blood efficiently to the body, including brain. Swelling ankle, feet. Of course, your appetite will go out of the window, as we talked about. Shortness of breath. So those are all symptoms of heart failure. And as we talked, it's okay to feel scared, but knowing that there's a support system available, healthcare available, and seeking medical attention when you realize those symptoms you are experiencing is the very most important part. Now, what you can do to keep your heart failure in check is checking and recording your weight every day, because that's your insight into when you're accumulating extra fluid. Because initially it's very subtle, and we don't want our patients to realize that they have accumulated a lot of fluid when it's too late. Accept your new normal. Yes, heart failure puts brakes on our gas pedal, which is called body. We don't feel as good, knowing that with treatment we can bring back some of that energy, but sometimes it's a reversible cause. We can reverse it. For example, if it's blockage, we can reverse the blockage by opening them up or treating the heart arrhythmia. It may bring heart pump to normal. So, but in some instances, we are not able to bring. If a virus has caused permanent damage to the heart muscle, not just coronavirus, but even the regular flu virus can affect heart muscle. And if the damage is permanent, well, that heart pump may not improve towards its full. But still, with the medicines, we can maintain a good lifestyle for a long period of time. Looking for signs, symptoms like swelling, rapid weight gain, labored breathing, and reaching out to your cardiologist when you have all those signs, symptoms. So moving on from heart failure, because the next devil, or I'll call it Godzilla in the line, is heart artery blockage, or the coronary artery disease. Coronary artery disease, the fancy name for heart artery blockage. We'll take a little slow approach here. I'm going to describe something which is a myth in the society from a long period of time. And a lot of time when I see my patients, whenever we find out I have heart artery blockage, it makes us anxious. Yes, it's normal to feel anxious because I have a heart blockage in the arteries. But if you knew, not every heart artery blockage equates to heart attack. That probably changes things. We always equate heart artery blockage to heart attack, and that's what makes my patients anxious all the time. And that's why I tell them first thing, that heart artery blockage does not always equate to heart attack if you're careful. Actually, I give them a very simple analogy of arthritis. So whenever I see patients, they have abnormal stress test or they're having symptoms and they find out that they have heart artery blockage, not heart attack. It's very important to distinguish between those two entities. These blockages, which are usually cholesterol laden, they develop over the period of months to years. They didn't start yesterday. They were there probably 3 months ago too, when my patient did not know they have it. They just got to know about it today. So it makes them anxious. But this was there 3 months ago also, 6 months ago also probably. Heart attack, on the other hand, happens because of a blood clot, a fresh blood clot, which clogs up the heart artery, shutting off the blood flow to the heart muscle supplied by that artery altogether. No blood flow. Heart is suffering. It needs to be opened up right away to help improving blood flow. Stents in that setting are golden. When somebody's having heart attack, it saves their life. It saves them their heart muscle, because longer time it goes after heart attack and artery stays blocked, heart muscle is gonna get scarred off. So in that case, stents work beautifully. They are golden. They save life. They save heart muscle. But there is important distinction between heart attack, which happens from a fresh blood clot forming in the heart artery, from a blockage, which is buildup of fat or cholesterol in the heart arteries, which probably started many months or years ago. And it's a stable blockage, slowly progressing. Probably it was 30% a year and a half ago. Now it's 50, then 60 and 80. At some point, it reaches to the critical point, for example, 70, 80%, when it starts giving chest discomfort to my patients. Now, here where I tell my patients, if you have arthritis, knee pain, and you go to a bone doctor, orthopedic doctor, is he going to take you straight to the OR and start putting knee implant? No. He's going to do everything to mitigate your pain, medicines, injections in your joint. Nothing works, then he's going to take you to OR and replace the joint. So he's doing everything to get your lifestyle back on track from that knee pain. If nothing works, implant. That's what same analogy applies to coronary artery blockage, which is chronic in nature. It's a buildup of fat and cholesterol. It started months and years ago, not today. And now it's giving chest pain. Same way the knee pain limits the lifestyle of my patients, a chest pain on exertion can limit their lifestyle. It can limit the quality of life. And that's where we tell them not every blockage needs a stent or open heart. Some blockages can be perfectly treated with medicine. Now, usually the counter question is your medicine going to dissolve my blockage? And I tell them, maybe. Not sure. Then they say, if it's not going to dissolve my blockage, then I should better have stent. So the goal in the heart artery blockage, which is chronic as nature, to one, get the medicine, knowing your medicine again, give the medicine or be on the medicine which are going to improve the blood flow to the heart muscle. Now, these are the medicine which are going to do the same thing what a stent is going to do, and hence usually preferred over stent as a primary treatment. These medicine relax the heart artery, improve the blood flow. What stent does? Stent improves the blood flow to the heart muscle, relieves the pain. What these medicines do, these medicines relax the artery, improve the caliber of the artery, and improve the blood flow to the heart muscle. Heart muscle becomes happy, pain goes away. So if that can be achieved with medicine, there's no need of a foreign body or a stent. So what I'm trying to say is, when I see patients who find out that they have coronary artery disease, the stable form, the chronic form, sometimes it takes time to explain, hey, not every blockage needs stent. Now, there are a few things where stent can still play a good role. If you find out you have heart artery blockage and it has weakened your heart pump, stent may be important to improve your heart pump. But believe me or not, more than 50% of my patients who have chronic, stable heart artery blockage, the heart pump stays good, normal. They don't need stent right away. They need medicines first. And many of the patients just get relieved by the chest pain they get from these chronic blockages. The fancy word is angina, gets relieved by those medicines. I call them liquid stent. Then they feel better. You're on liquid stent because it's going to do the same thing what's going to stent achieve. However, same way, like if your knee pain did not get better and your orthopedic doctor had to take you to the OR and replace the knee so you can enjoy your life. Same way, if your blockage is giving you chest pain, angina, quote unquote, and it's not getting better with medicine, hey, that probably needs stent in that case. So stents are reserved in a chronic blockage case for patients whose symptoms are not getting better with medicines alone, or in whom the blockage is causing heart pump weakening. So if somebody has coronary artery disease, what are your do's and don'ts? Well, the biggest factor is smoking, stress. Stress and smoking, if they can be managed, it can help keeping coronary artery disease at bay. Stress, emotional reactions, very cold weather, shoveling snow in the cold, big no-no, because it spasms the heart arteries and ruptures these blockages and can induce heart attack from them. So do's and don'ts for coronary artery disease, knowing your medicines well. If somebody has stent, a fresh stent, and what I try to hammer really hard after putting a stent in my patient, that your blood thinner is the most important medicine on your list. So knowing your medication part, knowing that you might be on medicines which will relieve angina, and if it completely gets rid of angina, well, you don't need stent. But if you happen to be in those patients in whom a stent is necessary, knowing that the blood thinner becomes the most important medicine on your list. And the blood thinners usually keep the stent going, because stents are foreign body, and when the blood crosses through stent, it can put blood clot on it because our body perceives it as a foreign body, and our mechanism of the body is, if it sees any foreign body, it's going to put blood clot on it. So if I put a stent in somebody's stable blockage and the pain goes away, but patient forgot taking his medication, especially blood thinner, what's going to happen? A big blood clot's going to shut down the stent, and patient's going to have a big heart attack. So just by putting stent and not taking medicine, we converted a stable disease into a heart attack. Would I feel good about it? No. That's why knowing medicine is very important, because sometimes not knowing medicine can be okay. But in this situation, in heart artery blockage, especially with a stent in, not knowing medicine can take life. It can be dangerous. So blood thinners are important. Now coming to one of the very controversial medicine for heart artery blockage called as cholesterol medicine or statins. There are multiple publications on it. It has a lot of bad publicity also, but you will notice one important thing about statins. All the cardiologists love it. And if they had it, they'll put it in the water supply of the town. Why cardiologists love it so much and people or patients who have to take it don't like it too much? One, yes, it can give muscle aches and pains, and it can actually, in some patients, it can damage the body muscles, not the heart muscle, the body muscle. But is it going to do that to everybody? No, it's not going to do that to everybody. Why cardiologists like the cholesterol medicine? Just because it lowers the cholesterol? Well, the truth of the matter is it's a myth. Lowering cholesterol is actually one of the signs that we know that the cholesterol medicine is working. Where we want to see the effect of the cholesterol medicine? Inside patients' heart arteries, especially patients who have heart artery blockage. Cholesterol medicine is wonder drug. That's the medicine which prevents heart attack, not stent. Patients with stable heart artery blockage, heart attack happens in them because these blockages can rupture because of high blood pressure, because of stress, because of smoking. Smoking releases chemicals in the body, inflammatory chemicals, which can rupture these blockages. And these blockages, when they get ruptured, the clotting cells of your body tries to heal that area and put a big blood clot and shuts off blood flow. Which medicine prevents rupture of your stable chronic blockage? Cholesterol medicine. And that's when I tell my patients, most of my patients tolerate it fine. Of course, it's important to know if it's causing muscle pain in your extremity muscles or it's causing Charlie horses and so forth. It needs to be switched to a different kind or stopped. In some patients, in about 15 to 20% of the patients, cholesterol medicine has shown to reduce the amount of blockage. So that's why when my patient, in the beginning of this conversation on coronary artery disease, I said, when they ask me, hey, you're going to put me on statin. Oh, sorry, you're going to put me on medication, not a stent, for my stable chronic blockage. Is it going to decrease my blockage? And I tell them, maybe. That's why I say maybe, because statins has shown to reduce the bulk of blockage and in some instances, significant improvement in blockage, but not in everybody. Science does not know clearly why those some fraction of patients respond so dramatically to statins. That's why cardiologists love statin. In those, it may not be able to decrease the blockage. It'll try not to progress fast. Know when to get help. Of course, angina, the pain, the chest pain. If chest pain is stable, you're only getting once a month pain, you take a nitroglycerin, it goes away, stable angina. But knowing if your symptoms are getting frequent, pains are getting harder, they are lasting longer, requiring multiple nitroglycerins, it's telling you that the coronary artery disease is progressing and you need help at that point. Moving forward, we talked about what is coronary artery disease. It's a narrowing of the heart arteries and reduction in the blood flow to the heart muscle, and heart muscle is being unhappy. And symptoms of fatigue, shortness of breath, or chest pain can all be from heart artery blockage. We talked about angina briefly. Prevention, of course, smoking is a big no-no. We're going to talk shortly about healthy lifestyle. It's not anymore a news for anybody, I think, that the smoking is bad for heart. So I'm not going to spend too much time on it. If anybody out there smokes, I'm sure they get enough fussing by their doctors. I call it fussing because fussing doesn't help anybody, but providing resources and knowing that willpower is the most important medicine which helps quitting smoking is important. Adopting healthy lifestyle, we're going to talk about that. Managing stress, we're going to talk about that. And exercising regularly. Blood pressure is very important part which can induce heart attack. So managing risk factors like diabetes and high blood pressure is very important because it can convert your stable heart artery blockage into a heart attack if they're not in check. So what you can do, know your warning system. Now, what is warning system? Warning system is every patient has warning system when they have chest pains, left side chest pain, going to arm, going to jaw. That's a typical heart pain. Does everybody get typical heart pain? No. That's the book definition of angina. Everybody does not get typical angina. My patients come with different symptoms. Some have shoulder pain, some have right-sided chest pain and right arm pain. Some have, very few had abdominal pain. So it can come in different shapes and sizes. Knowing what system Lord or nature gave you is important. For example, one of my patients came in with heart attack and the sole pain he had was in his belly. Everybody was looking around in his belly and the EKG showed heart attack. We fixed it, abdominal pain. Sorry, pain in his belly went away. So I told him, this is your warning system. If you'll have same pain again, likely it's coming from your heart. So that's why knowing your warning system, if you had pain, certain kind of pain which are established from heart, that's what's going to be your most likely warning system. Unfortunately, some patients do not have warning systems. Diabetic patients can have silent events and may not have any chest pain, and shortness of breath could be the sole symptom they might have from the heart artery blockage. Locating distance from the nearest ER or center where a stent can be placed in case of emergency. Why I brought stent here. Stent, as I said, that not every blockage needs stent, but heart attack, most likely, because that's the gold standard of treatment of heart attack. If one has blockage, should be looking around, should locate where is the nearest center can be located where they have stent placement capability. In the past, the treatment or the heart attack treatment used to be with a blood clot busting medicine, but now the standard of care is a stent. Taking your blood thinner seriously if you have stent. As I said, missing that blood thinner can lead to big heart attack from stent shutting down from a blood clot and can be very grievous or deadly. Keeping your nitroglycerin with you all the time because it's probably going to prevent a serious event. Sometimes patients may have chest pain not from blockage but from spasm in the heart artery or the spasm of the food pipe. Nitroglycerin can relieve all those pains. And reaching out to your cardiologist when you have worsening angina. Now, coming to the arrhythmias, we're going to quickly cruise through arrhythmia. Can we cover all arrhythmias? No, there are 20 different kinds of heart arrhythmia possible in the heart, but we will touch on the most common one as we grow, and that's atrial fibrillation. Atrial fibrillation is possibly second common rhythm after normal rhythm, after age 65 or 70. So most common reason we develop atrial fibrillation is aging, high blood pressure. Sometimes lungs disease can push the heart and put into heart arrhythmias. Sometimes certain infections can precipitate atrial fibrillation as we grow older. It can make heart speed up to significant levels that your blood pressure can drop and can make you dizzy. From that, it is not a life-threatening arrhythmia. Knowing your medication is very important in atrial fibrillation as well. Atrial fibrillation is not a life-threatening heart arrhythmia. It's a common heart arrhythmia as we grow, but it is a stroke-threatening arrhythmia. Nothing worries me about my patients when they have atrial fibrillation, but the risk of stroke. Yes, heart is speeding up. We can control it with the medicines, but stroke, if it happens and you're not in the hospital within 3 hours, the damage can be permanent. And atrial fibrillation-induced stroke happens to be big and devastating a lot of times. It happens because when the upper chamber, called atria, are fibrillating, they are literally not moving. They're just fibrillating. Instead of contracting, they are just fibrillating. And the blood stays stagnant in the upper chambers, in a tiny pocket of the upper chamber, which can make a blood clot because of stagnation of the blood there. And that blood clot can come out of the heart, and heart can mistakenly pump to the brain and can cause stroke. And hence, prevention of stroke is the number one thing for atrial fibrillation other than controlling the heart speed. And that's typically done by blood thinners, which can prevent blood clot formation. Knowing when to get help. A lot of time, my patients who have atrial fibrillation stay stable for a long period of time, but then suddenly the heart rhythm can act up and go fast. Usually, when they're stable on medicine and doing well, certain infections, in some patients it could be pneumonia, sometimes as simple as urinary tract infection, alcohol use, excessive alcohol use, those can make heart arrhythmia flare up and make your heart go fast and may need additional treatment or help from your healthcare provider. So atrial fibrillation, again, more than 3 million patients have atrial fibrillation in the United States. It's a heart rhythm disorder, not life-threatening, but stroke-threatening. Symptom, it can cause fatigue because when the heart beats fast, believe me or not, about 30 to 40% of the patients can't even feel that their heart is beating fast. They get to know that they have atrial fibrillation when they come to the hospital for some other reason, or pneumonia, and they get hooked up to the monitor, and here the heart is going at 130, 140, and that's how we find out that they have atrial fibrillation sometimes. And when the heart goes at a high speed for long enough time, for example, if it goes to anything over 120, 130 for constantly for days in a row or a week or two, it can weaken the heart pump. It can cause congestive heart failure, but it's a reversible cause. Once you control the atrial fibrillation, your heart pump recovers down the lane. It can cause chest pain, palpitations, dizziness because fast heartbeat can drop the blood pressure, and nothing because some patients don't feel anything. Sometimes we coincidentally find they come to see me for other reason, or they had to undergo a surgery and they needed an EKG before cardiac clearance, and here they have atrial fibrillation. So it can be sometimes asymptomatic as well. What you can do, no common triggers of atrial fibrillation, as we talked about, infection. Sometimes heart diseases themselves can cause trigger of heart arrhythmia, like heart artery blockages, and excessive alcohol intake, very high blood pressure, they all can trigger atrial fibrillation. Looking for signs and symptoms when condition might be getting worse, like rapid heartbeat, dizziness, passing out. Blood thinner is the mainstay of the treatment. As I said, nothing worries me about my patients with atrial fibrillation but the risk of stroke. And as far as they're taking their blood thinner, I'm happy because I know that the risk of stroke is on the way. Be careful with the sharp height near machinery. If you're on a heavy duty blood thinner, guess what? It can make you bleed. So if you fall from height and unfortunately hit your head on the ground and had bleed in the head, it's not good either because it caused a bleeding stroke now. So being careful with things which can make you bleed is very important, and seeking medical attention, as we talked about, if you feel that any of your symptoms you experience telling you that your condition is getting worse. Okay, changing gears about talking good things about life. As we said, we will concentrate on living as well. So living heart healthy lifestyle. So again, do's and don'ts. Some things we need to do, something we need to avoid. There are certain things we should not be doing. And most of the part kind of by this stage, we know do's and don'ts. And there are certain reasons why we as human have tendencies not to stick to those do's and don'ts. And we'll talk about them real quick. So there are 6 S's which your heart does not like, and he wants you to stop doing those. Smoking, no brainer. Not going to spend extensive time talking about smoking because pretty much everybody knows that smoking is bad. Now, who does not know that the stress is bad? Everybody knows stress is bad. And the stress management helps. Lack of sleep is a cardiovascular risk factor. A lot of young patients who work night shifts, I see, have palpitations. Sometimes they have heart arrhythmias. Lack of sleep can raise your blood pressure. It could be a key factor behind your uncontrolled hypertension, high blood pressure, which can lead to heart disease again. Sugar, diabetes in other sense, limiting your sugar intake. Steak, I use that word for cholesterol-rich food. Again, we know what other things not to eat, what other things to eat. Egg yellow, the most common source of high cholesterol in our diet are egg yellows. Seafood, except lean fishes, full of cholesterol. Shrimps, crabs, full of cholesterol. Lobsters, full of cholesterol. Seafood, egg yellow, red meat, steak, pepperoni, white meat, if you fry it, equally bad. So don't fry your chicken, don't fry the lean fish. It's as bad as red meat. So those are the common cholesterol-rich food we have, which we can eliminate. And the spirits, alcohol. Alcohol certainly can affect the heart muscle as well. So those are 6 S's to remember which heart does not like. Again, smoking, stress, sleep, sugar, steak, spirits. Stress management. Can I tell you don't take stress? No, I can't tell you don't take stress because I can't tell that to myself, because stress is part of life. Sometimes they say stress means life, life means stress, but that's not true entirely. How to manage stress? The only way I believe to manage stress is to put stress busters in front of the stress. There was an old saying, if somebody makes a line on the whiteboard and they ask you to make that line smaller without removing part of the line, you can only do that by making another line next to it bigger than that. And that will make the previous line smaller. Same way, if you put stress buster in front of the stress, more stress busters you have in your life, it can dwarf out your stress. Because life is going to bring its curveballs time to time, and stress can come, but you're going to deploy the stress busters. Exercise can work as a great stress buster. Exercise can work as a great mood lifter. Exercise can work as a great way to get a good sleep. So exercise works in a multi-channel way to make us feel healthy, better mood, and sleep. Hobbies. For some, it could be going in nature, taking pictures, taking photographs. For some, it would be sitting doing fishing. For some, it could be playing something out in the garden. So drawing, painting, hobbies bring stress-busting mechanism against stress. So look inward and answer which hobby rocks your boat. Stress management practices. Now, there are many established stress management practices out there which are scientifically proven to reduce stress. A few of which are mindfulness, being mindful about others, being mindful where you are, being mindful about your surrounding, being mindful about what things you have in your life which are good. Meditation. There are many kinds of meditation. Meditation doesn't mean you have to sit on one spot and you have to concentrate on your breathing. Meditation can involve concentrating. It brings focus, it brings mental health, and it has proven to improve multiple dimensions of health, including heart health. Yoga, it's a physical activity. Some are low intensity yogas. There is a moderate and high intensity yoga. Again, a good way to boost your joints and well-being. Practicing gratitude, believe me or not, there's a study on practicing gratitude. There's a book by name, A Little Book of Gratitude. I think these are written by one of the physicians up on the West in California. And there's a study on it that if you practice gratitude on a daily basis, can lower your blood pressure, can improve your mental health, and it can improve overall heart health as well. So moving here to physical activity. I know time is moving. We are almost towards the end of our presentation. Stick with me a few more minutes. Physical activity, we talked about it. What are the positive effects of physical activity on the body? It supports a stronger heart. So that's why they used the word cardio. You get your heart rate to a certain level on a regular basis, your heart gets stronger and stronger. A good sign of sometime a good heart health from a very conditioned patients, when their heart rates naturally stay a bit on the lower side. For example, if the heart rate range is 60 to 100, and at rest, if somebody's heart rate is sitting around 60s and 70s, that could be a sign of good heart health in compared to somebody's who is sitting on the higher side of the spectrum, like 90s or 100s. It improves your circulation, lifts your mood and self-esteem, as we talked, reduces stress. It promotes positive hormone release in our body, promotes sleep, lowers your blood pressure, cholesterol, and sugar, and helps you manage weight. So it helps. We know about it. How much physical activity is enough, at least? So American Heart Association suggests that we do 150 minutes per week, moderate intensity. What is moderate exercise? On your right side, there's some examples. You do brisk walking, dancing, gardening, or household chores like vacuuming. They are considered as moderate intensity activity. And 150 minutes every week, or 75 minutes, half of that, vigorous activities like aerobics. If you add some weights to it, if you can afford, then muscle strengthening activity can help. Of course, it can range from moderate to high intensity as well. Okay, coming to the diet, what things we are not supposed to do in the diet. It's no-brainer again. Salt, but there's a little bit more information needed on the salt. Rather than just telling you, hey, don't take salt, don't eat salt, maybe a little bit more will be helpful. We know no smoking is important, so you don't buy cigarettes and you don't smoke cigarette. But when it comes to salt, I can't tell you don't buy salt because it's hidden everywhere. It's hidden by the food industry everywhere. And food industry is here to make profit. And guess who they make profit on? Us. So reading labels when buying anything from bread to any processed food, some processed foods are bad anyways, but including anything which comes in a canned food, canned soups full of sodium because sodium acts as a preservative in it. Canned vegetables, salt again is preservative in that. Eating out. Well, when you're eating at home, you can control how much salt is going in there. When you're going to a restaurant, you can't. You may not add anything on top, but your food may have enough salt already to get you off your track if you have heart failure. And using other spices can help substitute. So yes, no salt or little salt can make your food bland and not eatable, but using other spices, oregano, the Italian spices, the Indian spices, which may not have salt in them, but they may make food flavorful enough to make it edible. So those are certain things. On the upper hand, there's some cues how much sodium is enough. Of course, no more than 1 teaspoon typically is recommended, not to be eaten in an entire day if you want to avoid less amount of salt. In patients with heart failure, probably even less. Sugar, we know it's hidden everywhere like salt. It's everywhere. If you can see, added sugar is hiding in fruits and vegetables which come in can. Your drinks, especially sodas, snacks, sweets, your cereals, prepared dishes, and food. As I said, food industry is here to make profit, and they will change the name of sugar, but it's going to stay sugar. You call it high corn fructose syrup, it is sugar. You call it agave syrup, fancy, still sugar. This soda does not have sugar, it has cane sugar. It is still freaking sugar. So they will change, they'll call it lactose, they'll call it malt, but sucrose, it is all sugar. Rice syrup is also sugar. All sugars are bad. Alcohol, we talked about it, it can weaken your heart muscle, can cause heart failure, can trigger arrhythmias, atrial fibrillation. Other atrial arrhythmias can be triggered by alcohol use. Severe heart pump weakening can lead to trigger of bad cardiac arrest like arrhythmias too, which can be caused by alcohol abuse. So it creates more stress, degrades your sleep quality. And sleep is also a cardiovascular risk factor. Remember, lack of sleep is a cardiovascular risk factor. Caffeine, nobody talks about it. I think it's the second biggest conspiracy other than smoking. There are articles out there, caffeine helps this, caffeine helps that. It does not help. Caffeine degrades your sleep quality. It does not let your body go into the deepest phase of your sleep. And guess what? Most of the day-to-day wear and tear we get in our body from radiation exposure, from cosmic radiation exposure, the minor DNA damage, our body heals it, repairs it during the deep phase of sleep. And if your body never gets to deep phase of sleep, your body repair is hampered. Caffeine raises blood pressure if taken in significant amount. It can trigger heart arrhythmias. It can trigger atrial fibrillation if you take a significant amount of caffeine. Promotes anxiety. Caffeine can affect heart in multitudes of ways. This last part, I'll take a couple of minutes. I know time is almost over, but we started a couple of minutes late, so I'll take that point to my advantage. Sorry about that. This is the important slide about the diet, if you see, and it's about the food psychology. We talk, by now we know what to eat, what not to eat, what to do, what not to do. And this particular slide applies to not only food, it also applies to exercise, applies to smoking, applies to alcohol, applies to sugar, applies to cholesterol, heavy food, everything. It's our inner dialogue. Until you turn inwards and watch your inner dialogue, see what our food devil and food angels are talking about. Until then, it's not possible to be on the right track. Most of the adults know what to do, what not to do in this world, but we still have heart disease here. We still have so many health problems, diabetes, hypertension here because of the psychology. If we know and if we become consciously aware why we are making certain choices, we will have more power to revert it. If you pay attention today onwards that you do have a food angel in your head and you have a food devil in your head, and they are having discussion every time you see a certain food. For example, a lot of us, we have different rules. We have different meanings to the food. And that's what driving us to eat all these unhealthy choices we are making. For example, if you have a rule, oh, it's a rainy day and it's a Sunday, it's a pancake day. That's a rule. Who made that rule? I don't know. There are certain rules. Well, I worked hard today. I'm going to treat myself. I had a promotion today. I'm going to treat myself. I had a bad day. I'm going to treat myself to feel better. So many rules. So we connect. This is the food devil in your head. Whenever you see something unhealthy and healthy choice, your food devil and your food angel are talking to each other. And food devil in your head is saying, maybe one time, let's do this one time. You had a hard day, you got dumped, you got fired, or you got promotion, or it's a rainy day, oh, it's Christmas, oh, it's your birthday, let's have cake. So your devil in your head is constantly trying to win from your angel. Your angel says, yeah, he's right. Yeah, maybe one time is okay. But that one time, every time becomes 100 times. And the food angel, on the other hand, so if you come in the middle of this discussion and hear that, you can make a better choice. And some of us feel it's a freedom to eat everything, but actually, it's not a freedom. A choice, making a choice of not eating something is also a freedom. And more we watch our inner dialogue and more we know about food psychology, you can apply the same thing for exercise. Oh, it's weekend. I had a hard week. I'm not going to exercise today. Again, the devil speaking in the head, trying to win from the angel. So watching your inner dialogue and knowing what conscious things are, subconscious things are happening in our head can make you help make the right choice for you. On that point, I'll say thank you.
Great, thank you so much. At this time, we'll take a 5-minute intermission. During the break, a pop-up window will appear on your screen to collect some basic audience information. Please complete this poll by making your selections and clicking submit. We'll also have our Q&A session after the intermission. Just a reminder that the MIDI Medical School attendees may type questions throughout the session using the Q&A button at the bottom of the screen. We will address these questions after the intermission. And one last thing, there will be also a survey with some questions we ask you to answer after the session tonight. I'll remind you of the survey after the Q&A session.
So we're going to go ahead and start with the Q&A session.
Okay.
One of the first questions that we have was posted by one of the attendees, and they asked what the shelf life of nitroglycerin is. They have AFib and they've carried the same pills for 5 years.
Nitroglycerin, typically I tell my patient if it's more than 1 year old, you better buy M&Ms and eat them because they'll taste better. They don't work after 1 year, and they just dust or powder, that's it. So a few things about nitroglycerin. Since somebody asked me about nitroglycerin, I tell them do not swallow it. It's something gets absorbed under your tongue, so let it dissolve. And number two, find a chair before you do it. Otherwise you can get dizzy and can fall from that. But yes, about 1 year or more, they're useless. And nitroglycerin does evaporate. Liquid nitroglycerin we use in our procedures, if it stays in touch with air too long, it's gone. So yes, it's not useful after a year. Atrial fibrillation, usually it's for chest pain. But yeah, if it's more than 1 year old, call your provider and get it changed now, as soon as the session is complete.
Yeah. Great, thank you for that answer. We don't have any other questions from the attendees, but if they do, they can go ahead and type those now. I do have one question. You mentioned that diabetics often have silent warning signs for heart attacks. And I was just wondering if we knew why that occurred, or if this just is something that we've noticed.
Diabetics tend to have neuropathy. Neuropathy everywhere. Neuropathy in the legs, which causes tingling numbness there. It typically, if you read in the books, it says gloves and stocking neuropathy. So they lose sensations here. That's why they burn their hands. Why they burnt their hands? Because when the hand was on the burner, they didn't feel it. Same neuropathy can ensue in the nerves, which is supplying the heart and the chest wall. So they don't get any referred pain. The pain from the heart happens because of the referred pain on the chest. That's why there is so different distribution of chest pain. Some get in the shoulder, some get in the pinky. You know why? Because that nerve which supplied the heart went to pinky in that patient. So if there is neuropathy of that nerve, they are not going to feel the pain. And that's why shortness of breath is called angina equivalent for those patients.
Great, thank you.
And then I had a question as well. You mentioned throughout the presentation, especially towards the end, that you offered some resources to your patients. Could you list a couple of those that help them maybe quit smoking or change their diet? Like, what are the things that you try and provide your patients with to help mitigate those behaviors?
So, couple of things. First of all, for information and knowledge, American College of Cardiology has this CardioSmart portal, and American Heart Association has heart.org. So knowledge can be gathered there. Those are good resources. Mayo Clinic has a good resource on the website for education's sake. When it comes to quitting smoking, there are many organizations. You can just Google them, quitting smoking. There is a helpline number also available. I don't remember on top of my head, but we can certainly email it to you guys and you can provide it to attendees later on. There's a helpline number to call to the organization so that they can get free goodies bag. That's what my nurses give me to give my patients goodies bag. What is there? Of course, there's information in that goodies bag. There are no goodies. Sometimes there are the nicotine gums there. Nicotine patches are a bit expensive, so they are not in that goodie bag. Usually your insurance has to pay through the pharmacy. So, but as I tell my patients, the most important medicine to quit smoking is the willpower. In the absence of willpower, nothing is going to work. So if you have willpower, we can aid with other things. There are other alternative therapies available. I've heard hypnosis works in many patients quitting smoking. I don't know how that works. Maybe that I will do after retirement. I'll learn hypnosis. So those things work. The other important thing to know is you cannot stop a bad habit. You can replace it with a good habit. So here I'm not talking about replacing it with the e-cigarette, equally bad for heart. Not replacing it with e-cigarette, but replacing it with some other habit. For example, if your body tries to get cues for smoking, get up and start running. When the body, the good hormones will release, it'll cut down your craving, and because of running, you'll get physical activity. So you're killing two birds with one stone. So you can replace a habit, but you cannot stop one habit. So willpower, replace the habit, and there are trying alternative therapies. I try not, if they need pharmacological intervention, we give them, but trying alternative therapies and replacement habits work really good as well. Well, I'll provide the link and the contact number of the organization which helps with quitting smoking. I can provide with the email. And if there's a way to send them to attendees, I apologize, I don't have the number on top of my head.
Thank you. And then also going off of that, what do you recommend, especially like here in Terre Haute, and we're both in the rural medicine program here. So what do you recommend for patients who are trying to improve their diet? Because I know that there are a lot of difficulties in obtaining good food in rural communities, especially. So any recommendations on that side of things?
So most of the things are simple in life. Sometimes they appear not that simple. When I was in public health, I learned a few things from my community health teacher in the class, or lecturer in the class, or instructor in the class, whatever you want to call it. Stay on the periphery of the grocery store. Don't go in the center. Most of the decent stuff is on the periphery. Avoid things which are pure, like sugar, salt, heavy dairy products, all are white in color. Anything which is solid at room temperature, like butter is solid at room temperature, margarine is solid at room temperature. So just few basic cues. Even if they ask me for diet, I tell them, as far as you get rid of egg yellows, don't fry your food, stay away from red meat and seafood, you're done. 90% of cholesterol is gone. You stay on the periphery of your grocery store, another 5% eliminated. Stay away from things which are solid on room temperature, oils which are solid at room temperature, and avoid things, the edible stuff which is white in color. You are safe almost 99%. Avoid canned vegetables, fresh, then frozen, then canned. That should be the increment. So that's for diet. There are local dietitians available who wants to dive deeper. I probably will make a flyer of smoking and diet and send it to you through email. But there are dietitians available. Some of my patients who are interested in taking a deeper dive, I refer to the dietitian. Again, most of the other diets, okay, some diets are heavy on fat. There's keto diet. There's always a fad, or there's always a fashion. There will be a new diet always there and a fashion available. But that fashionable diet, which is good now, will be proved bad 6 months later, and a new diet will replace it. None of them work because they don't work on behavioral psychology. If anybody wants to change their diet, they need to look inward and look at their food dialogue. Once you're aware about your food dialogue, you start to see changes efficiently. But I'll provide the numbers for that as well on the flyer.
Thank you so much.
And we do have one other question from an attendee. Jim is asking whether or not atrial fibrillation is fatal.
Good question. Atrial fibrillation is not a life-threatening arrhythmia. It is very common arrhythmia. It's probably the most common arrhythmia. It's a second normal rhythm after age 75, if I should say so. It's not life-threatening. However, if it can speed up your heart enough to drop your blood pressure and make you dizzy, and you're on the wheels, you're driving, it can be fatal that way. So if you are one of those who tend to have atrial fibrillation where your heart speeds up frequently, it's not under control, avoid driving, avoid getting up on the ladder, avoid going near a major machinery or a tractor. So those are just more common sense things, but in itself, arrhythmia will not kill anybody. Atrial fibrillation will not. It doesn't lead to cardiac arrest. There's a very specific patient population, especially young patient population, who have something called, a cool term called WPW syndrome, other words called Wolff-Parkinson-White syndrome. They are the ones in which atrial fibrillation can be fatal. But as I said, that's like probably less than 1%. That's like 0.1% of the patient population who have AFib, and they tend to have AFib in their 30s. So not only nature gave them WPW, nature gave them WPW very early in the age. In them, it's fatal, but largely 99% of the patient, it's not.
Great, thank you for that explanation. I don't think we have any other questions, so that will conclude tonight's mini medical school session. Thank you once again to Dr. Bhatheja for presenting, and thank you to our attendees for joining us tonight. We'll hope that you join us again next week. Mini medical school sessions happen every Tuesday in March and April from 6:30 to 8:30. And next week's topic, I believe, is going to be over GI health. And before ending this meeting, we do ask that you answer some survey questions that will appear on your screen. Your feedback is anonymous, and we will be using your answers to plan for future mini medical school sessions. Thank you all and have a great night.
Thank you. Have a great night, and thank you for letting me help few people, and hopefully it was helpful to those who attended. Thank you. Bye.